Okay, good morning all. Today's topic is ECG changes in the myocardial ischemia, infarct, and due to other metabolic factors. So, today, myocardial ischemia. Severe narrowing or the complete blockage of the coronary artery causes the blood flow to become inadequate, leading to the ischemia of the heart muscle. Ischemia to me means literally to hold back blood. Myocardial ischemia may occur transiently. Then, the coronary blood supply. The cardiac blood supply is delivered by the three main coronary arteries and their branches. The first one is the right coronary artery, the left coronary main artery, which divides into the left circumflex artery and the left anterior descending artery. The right coronary artery supplies both inferior portion of the heart and the right side part, that is the right ventricle of the heart. Then the left main coronary artery is a short, divides into the left anterior descending coronary artery, which supplies the septum and the large part of the ventricular free wall. And the left circumflex artery, coronary artery, supplies the lateral part. So the left circumflex, the lateral part, whereas the left anterior descending, the septal wall and the major part of the left ventricle. And the right coronary artery supplying the inferior and the major part of the right ventricle. So the ECG changes in the myocardial ischemia. Most of the patients who present with the acute MI have underlying atherosclerotic coronary artery disease. The pathophysiology of the acute STEMI and the subsequent evolving Q waves MI most oftenly relates to the occlusion of the one of the coronary arteries by a ruptured atherosclerotic plaque, followed by the formation of the clot at this site, leading to the blockage of the blood to the heart. The earliest changes seen in the ECG with acute transmural ischemia, in fact, typically occurs in the ST-T complex in the sequential phases. So the transmural means it involves the entire wall of the ventricular wall, whereas the other types, it can be subendothelial type of ischemia, which involves the subendocardial ischemia, which involves the endocardium. The acute phase is marked by the appearance of the ST segment elevation and sometimes the tall hyperacute T waves in the multiple leads. So that is why this is called ST segment elevation MI STEMI. Refers to this phase of this acute phase is called the STEMI phase. The evolving phase occurs hours or days later and is characterized by the deep T wave inversions in the leads that previously showed the ST segment elevations. So in the leads which previously showed the ST segment elevations, now after few hours or days in the evolving phase, we can be seeing the deep T wave inversions. Then the transmural myocardial infarcts can also be described in the terms of location of the infarct. Anterior means it involves the anterior or the lateral walls of the left ventricle, whereas the inferior indicates the involvement of the inferior wall of the left ventricle. Then acute anterior wall MI, the ST segment elevations and the tall hyperacute T waves appear in one or more anterior leads, that is the chest leads from V1 to the V6, and the extremity leads like lead 1 and the AVL. With the inferior wall MI, the ST segment elevations and the T wave hyperacute tall T waves are seen in the inferior leads. What are the inferior leads? Second, third and the AVF lead are the inferior leads. So the ST segment elevation and the reciprocal ST depressions are the early ECG changes of the infarct and generally seen within the minutes of blood flow occlusion. Tall positive T waves may also be seen at this time. After the variable time lag, usually hours to the few days, the elevated ST segment starts to return to the baseline. At the same time, the T waves becomes inverted in the leaves that had previously shown the ST segment elevations. This phase of T wave inversion is also called evolving phase of infarction. Then the abnormal Q waves are the characteristic markers of the infarction. They signify the loss of the positive electrical voltage caused by the death of the heart muscles. The new Q waves of any myocardial infarction generally appear within the first day or so of the infarct. Not the ischemia, it's the infarct. So these are the locations on which basis we can, location of the infarct combinations. Depending upon these locations of the changes in the ECG leads, we can detect the location of the infarct. So the first lead AVL, it indicates the lateral part. Second, third, and the AVL, the inferior part. V1 and V2, the anterior posterior part, and the anterior and posterior part, and the anteroseptal part from V3, V4, and V5, and the anterolateral part by the V5 and V6. So based upon this, we can find the location of the infarct. Then the ECG evaluation. In non-reperfused myocardial infarction, it is, see, you can see the normal change. Then the peak T waves, the T wave is peak, which is seen in within minutes. The progression of the ST segment elevation. So slowly the progression of the ST segment elevation, which takes around minutes to hours. Then the loss of the R wave and the Q wave formation. This is around hours to days. And the T wave inversions. So see here, Q wave is this one, and here Q wave and the T wave inversions we are seeing, which is usually from days on. T wave normalization and the persistent Q waves. That is, it can take days, weeks to months. Here you can see the Q wave, but normal T wave. So initially the peak T wave, later the progression of the ST segment elevation, and then the loss of the R wave and the Q wave formation, finally the T wave inversion, and this is the old infarct changes, which we see the Q waves and normalization of the T wave. So the ST segment elevation in MI. So ST segment elevation, if it is more than 1 mm, that is significant ST segment elevation, which is seen in the 2 consecutive leads. So in the lateral, as I said, V5, V6, AVL, and the first lead we will be seeing. Whereas V1, V2, V3, and V4, these are the anterior leads, and 2, 3 AVF are the inferior leads. So the same one I am repeating here, the acute ST segment elevation, loss of later within hours. ST segment elevation, decreased R wave, Q wave begins, and later 1-2 days later the T wave inversion, Q wave deepening, and later few days later again ST segment normalization, T wave inversion, and the weeks or months the ST segment and the T wave becomes normal, but the Q waves persists. See, this is the chest leads for the patient with the acute anterior wall MI, in which we can see the ST segment elevations. See, are you able to see this ST segment elevations? So in the acute stage, this is the acute stage. This A1 is the acute stage in which the STEMI is seen. ST segment elevations with hyperacute T waves. And several hours later, see the marked ST segment elevations we are able to see here. And the abnormal Q wave is also almost ready to form, which we can see in V1 and V2 leads. This is an acute anterior MI. This is the variable types of ST segment elevations in the acute myocardial infarction. See. Then, the anterior wall Q wave infarcts. The characteristic features of the anterior wall Q wave infarcts is a loss of the normal R wave progression in the chest leads. As we know that R wave, the height of the R wave progressively increases as we move from the V1 to the V6 leads. An anterior wall infarct interrupts this progression and results in the pathological Q waves in one or more chest leads. And even the loss of the normal R wave progression is also seen in the anterior wall MIs. So this is the anterior wall MI. So here you can see this is the acute stage in which you can see the ST segment elevations. I think you are able to see the ST segment elevations, and this is the evolving phase in where we can see the again P wave inversions, and the resolving phase in which the ST segment elevations have been completely become normal, T waves have been normal, whereas we can see the Q waves. So here, this is the anterior wall MI. Here we can see the reciprocal ST changes. Reciprocal ST changes in the inferior walls. So this one, I think you're able to see. These are the reciprocal changes. See here the T wave inversions are seen, whereas in the reciprocal changes, T wave. Okay, these are the reciprocal changes in the anterior wall infarct. Then anteroseptal Q wave infarcts. The R wave, the small R wave means the R wave is very small in the leads V1 and V2 may disappear entirely, and the entirely negative QS complex may appear. This indicates the anteroseptal infarcts. So here you can see almost R wave almost in its difference, and the ST segment elevations, T wave inversions we are able to see, right? These are the septal. Septal means usually within V3, V4 and V5. Even the V2 also can be seen. These are the anteroseptal. So the most of the part is covered in this. And this is the old anteroseptal MI. Here you can see the Q waves clearly, and the T wave inversions are present. So it is after few days or few weeks of the anteroseptal infarct. Then the anterolateral or the anteroapical Q wave infarcts. And infarcts of the anterolateral or the apical wall of the left ventricle produces the changes more in the laterally situated chest leads like V5 and V6. So abnormal Q waves as a part of QS or QRS complex may appear in the V5 and V6. The anterior infarcts that is associated with the large Q waves in the leads from V1 to the V6 usually represents the extensive damage and leading to the reduced left ventricular functioning and the ejection fraction. That leads to the reduced ejection fraction. So here we can see the complete from V1 to the V6 ST segment elevations, T wave, tall T waves you were able to see, but still the Q waves are not completely formed. So the inferior wall infarcts. The infarcts of the inferior wall portion of the left ventricle is indicated by the changes in the leads, as I said, 2, 3 and AVF. So the inferior wall infarct may produce the abnormal Q waves in the lead 2, 3 and the AVF. So here these are the ECG sequences of the inferior wall Q wave formation. So initially the acute phase in which the ST segment elevation we are able to see what are the inferior leads, the 2, 3 and the AVF. Here we are able to see the ST segment elevations, right? And then a new Q waves formation is also we can able to see. This is the Q wave in the second, third and the AVF lead. Then next, evolving phase, in which we will be seeing the T wave inversions here. In the second lead, T wave inversion, third lead, T wave inversion, and the AVF, the T wave inversion. So this is the resolving phase in which the ST segment and the T waves becomes normal, and we can only see the Q waves. So here Q waves and the ST and slow. This one is the ST. So it is not elevated, it is the flattening of the T waves we are able to see. The reciprocal ST changes in the anterior leads. So we can see the reciprocal ST changes in the anterior leads. So 1, AVL, V2 and V4. See here also. Reciprocal changes we are able to see. Right? Almost the reciprocal changes we are able to see. Then the posterior infarctions. So infarctions occur in the posterior surface of the left ventricle. This may be difficult to diagnose these because a characteristic abnormal ST elevations may not appear in any of the 12 leads, conventional leads. Instead, the tall R waves and ST depressions may occur in the lead V1 and V2, the reciprocal to the Q waves and the ST segment elevations. So it is a reciprocal changes we are seeing which in V1 and V2. That is a large R wave which is a reciprocal to the Q waves, and ST segment elevations which is reciprocal to the ST segment. Depressions which is reciprocal to the ST segment elevations. During the evolving phase of these infarcts, when the deep T wave inversions appear in the posterior leads, the anterior leads show the reciprocal tall T waves. So here, so this is a posterior infarct in which, as I said, V1 and V2, we will be seeing the tall R waves and T wave. See, V5, V6 and all T wave inversions we are able to see. Probably this is a lateral wall infarct is also present. Even the patient is having the Q waves in this one, so it may be the inferior wall infarct. Reciprocal changes we are able to see in V1 and V2. That is a positive T wave we are able to see in the V1 and V2. This is the old posterior MI. So instead of Q waves, we'll be seeing the R wave here. Then the ventricular aneurysm. After a large myocardial infarct, a ventricular aneurysm develops in some patient. An aneurysm is a severely scarred portion of the infarcted ventricular myocardium, thus does not contract normally. So the patients with a ventricular aneurysm frequently have persistent ST segment elevation after an infarct. As mentioned earlier, the elevations, the ST segment elevation seen with the acute infarct generally resolve within several days. The persistence of the ST segment elevation after several weeks or more is suggestive of the ventricular aneurysm. So left ventricular aneurysm, the ST segment elevation is seen more than after even 2 weeks following the acute myocardial infarction, most commonly seen in the precordial leads, may exhibit concave or convex morphology, usually associated with well-formed Q or QS waves. The T waves have relatively small amplitude in comparison to the QRS complex. The factors favoring the left ventricular aneurysm means it's usually identical to the previous ECG, absence of dynamic ST segment changes, absence of reciprocal ST segment depressions. So this is the difference in which we can know it is a left ventricular aneurysm. Then the factors favoring the acute STEMI is new ST segment changes compared to the previous ECG and the progression in the ECG changes. So the degree of the ST segment elevation increases on the serial ECGs. Reciprocal ST depressions are seen. And the clinical symptoms can also be present in the acute MI. So here, this is the ECG. Still we are able to see here the ST segment elevation, but the T wave is not that much, and the Q waves are completely formed. T waves, it's almost flattening, or it is a normal. Then the myocardial infarct with RBB. The diagnosis of the myocardial infarct can be relatively easy with RBB, can be easily diagnosed when compared to that of LBB. The right bundle branch block affects primarily the terminal phase of the ventricular depolarization, producing a wide R wave in the right chest leads and the wide S wave in the left chest leads. So the myocardial infarct affects the initial phase of the ventricular depolarization, producing the abnormal Q wave. So it is easily detected. The QRS complex is abnormally wide as a result of bundle branch block, leading to, in the lead V1 shows a terminal positive reflection, and the V6 shows a wide S wave. If the infarct is anterior, the ECG shows the loss of R wave progression and the abnormal Q waves in the anterior leads. If it is inferior, the pathological Q waves and ST segment elevations are seen in the leads 2, 3, and AVF. So this is the acute anterior wall STEMI with RBP. So here you are able to see the widening of the QRS complex with terminal R waves in the lead 1 and lead 2, and appropriate S in the V3s. So here we are able to see the ST segment elevations also, which indicates the MI, and the Q waves in the lead V1, V2, and V3. Okay. Then the myocardial infarct with left bundle branch block. The left bundle branch block interrupts both the early and the late phase of the ventricular stimulation. It also produces secondary ST changes. So what is the criteria that we are using to find out the myocardial infarct with a left bundle branch block is Darbo's criteria. In this, the ST segment elevation more than or equal to 1 mm in the leads with positive QRS complex, it gives around 5 points. ST segment depression more than or equal to 1 mm in the leads V1, V2, V3, 3 points. And the ST segment elevation more than or equal to 5 mm in the leads with negative QRS complex, 2 points. If the score is more than or equal to 3, 90% of specificity and 20% of sensitivity. So based on this criteria, we are diagnosing we are able to find out the myocardial infarct with the left bundle branch block. So here criteria, any leads like convexity greater than 1 mm, and here greater than 5 mm, and here in the V1, V2, V3 greater than 1 mm ST segment depression here, concordant, and here. Okay, this is any leads criteria A and C, whereas in the B, V1, V2, and V3 leads. This is the Garbo's criteria. Then the subendocardial ischemia. The most common ECG changes with the subendocardial ischemia is the ST segment depression. The ST segment depression may be limited to the anterior or to the inferior leads, or it may be seen more diffusely in both group of leads. In many cases, however, the myocardial ischemia may be limited primarily to the subendocardium, the inner layer of the ventricles associated with ST segment depression rather than primary elevation. So here, the subendocardium is usually exposed to the high pressure of the left ventricles and are the areas where which get the blood supply comparatively less. So The subendocardial ischemia can also be seen. This is the subendocardial ischemic waves. Here we see, so like this, it leads to the depression, whereas here elevation we are able to see. So these electric forces arrows indicate the electric forces, and these leads to the this type of changes in the ECG. So here in the transmural injuries, it is towards the outside layer of the heart, so ST segment elevation is seen, whereas it is towards the inside layer of the inside in the subendocardial injury, so ST segment depressions are seen. So these are the ST segment depressions which we see in the subendocardial ischemias. So this is the isoelectric range, the pathological Q wave. This is the STEMI type, so ST segment elevation and the T wave inversion. Whereas in the ST segment depression in STEMI, here the ST segment depression and the T wave inversion in the non-ST segment elevated MI. So these are the ECG changes which we see. This is a non-Q wave, in fact, in the patient complaining with a severe chest pain. So here we can see the acute ST segment depressions in the lead 1, 2, 3, AVL, V2 to V6, right? And conjugation with the ST segment elevation. This is the reverse wave. So in AVR, this is a severe subendocardial ischemia, mainly possibly due to the left main obstruction. So almost all the leads we are able to see, the anterior leads, the lateral leads, almost all the leads we are able to see the changes. So now in case of angina, like the patient, if the patient is having the anginal pain, during that time we can see the ST segment depressions which we are able to see here while being examined. After a few minutes later, if we give the patient sublingual NTG, here again the ST segments reverse to be normal with the relief of the pain, angina. Then in case of angina type of pain, if we the normal rest ECG may be normal. So at rest the patient may have normal ECG. In these cases we'll be using the treadmill test, in which the patient is asked to walk on the treadmill and the ECG is taken based upon the exercise. So this, in the rest it is normal, and here in the exercise, during exercise, the patient is having ST segment depressions with increased heart rate. So this is the condition which we see. Means these are early changes that we are having. Subendocardial ischemic changes are there. So the myocardial ischemia, non-infarction, subendocardial ischemia, so transient ST depressions, which can be normalized with normal again when the angina is relieved. Whereas the non-Q, non-ST elevation infects the ST depression, T wave inversions without the Q waves. The transient transmural ischemia, the transient ST segment elevations followed by the T wave inversion. The classic ST segment elevation Q wave infects, new Q waves usually preceded by the ST segment elevation followed by the T wave inversion. So these are the acute coronary syndrome ECG findings. Now we are able to see, right? This one is a normal one. Whereas then unstable angina, as I said during the episode of angina, the patient may have ST segment depressions, horizontal ST segment depressions, and this one is the downsloping ST segment depressions, T wave inversions. Whereas in STEMI, we can be seeing the ST segment elevations. So the differential diagnosis for ST segment elevations. The ST segment elevations can also occur in the older persons, pattern similar seen with the acute pericarditis. Chronic ST segment elevations are often seen in the lead V1 and V2 in association with the patterns of LVH and LVB. The other causes of ST segment elevation includes the systemic hypothermia, in which the J waves or the Osborn waves are seen, and the Regadas pattern. So this is the difference which helps to differentiate between the STEMI and the acute pericarditis. So here, check for any T wave depressions, right, or ST segment elevation. See here, more in the lead 3 when compared to the lead 2, and this is convex type of upward ST segment elevations, and the RT signs, the check mark sign. The factors favoring strongly the pericarditis, PR depressions in multiple leads, and T wave, spodic sign, TP segment downward sloping is seen. An important subset of the patients with ischemic chest pain presents with the deep coronary T wave inversions in multiple precordial leads, with or without cardiac enzyme elevations, and with minimal or no ST segment elevations. This pattern is called Wellness syndrome or LADT wave inversion pattern, and is typically caused by the tight stenosis in the left anterior descending coronary artery. So in this type of condition means like tight stenosis of the left anterior descending coronary artery, it leads to the deep T wave inversions in the multiple precordial leads, with or without enzymes elevation, with or no ST segment elevations. And the very deep, widely splayed T waves inversions with long QT interval and sometimes prominent U waves have been described. In some cases, patients with cerebrovascular accidents, particularly subarachnoid hemorrhages. So very deeply the T wave inversions with long QT intervals and prominent U waves. So here, this seen the giant T wave inversions, we are able to see this is a ECG of the subarachnoid hemorrhage patient. Deeply inverted T waves with marked prolongation of the QT interval. See, we are able to see the marked prolongation of the QT interval and the deep T waves. So this is an ECG of the subarachnoid hemorrhage patient. Then benign repolarization, the widespread concave ST segment elevations, notching on slurring at the J point, prominent slightly asymmetrical T waves, and no reciprocal ST depressions to suggest the stemming. ST changes are relatively stable, so no progression is seen in the serial ECGs. So here is the early repolarization. Here the ST segment elevation usually marked in the chest leads. So here it can be confused, but we don't see the reciprocal changes which we will be seeing in the myocardial infarct, and even the serial ECG ST segment elevations are also not seen. That is what we mentioned, and even the notching of at the J point, prominent and slightly asymmetrical T wave that are coordinate with QRS complexes are seen. This hypertrophic obstructive cardiomyopathy is showing the pseudo-infarct Q waves that results from the septal hypertrophy. Pseudo Q waves. Due to septal hypertrophy, we'll be seeing this pseudo-infarct Q waves. Then, now we will discuss about the ECG changes in the metabolic disturbances, metabolic factor disturbances. Now, the electrolyte disturbances, first most common electrolyte disturbances which leads to the changes in the ECG and the cardiac connection are the potassium. So hyperkalemia, the first change seen with abnormal elevation of serum potassium concentration is narrowing and the peaking of the T waves. The T waves with the hyperkalemia have characteristic tended or pinched shape, and they become quite tall with future elevation of the serum potassium concentration, the PR intervals becomes prolonged and the P waves become small or may disappear entirely. So what is the first change? We'll be seeing the peaking of the T waves, later followed by PR interval increase, prolonged, and then the P waves may be either small or can be disappeared. And the continued elevation may produce the intraventricular conduction delay with widening of the QRS complex. So here, what are the changes? First, T wave peaking, then prolonged PR, then the P wave small or disappear, then the widening of the QRS complex. So here, the mild to moderate changes hyperkalemia. Now here we can see the peaking of the T waves, right? Then moderate to severe, the PR prolongation we will be able to see, and the small P waves will be seen. See here, and then the peaking of the T waves, right? See, the P wave is very small, and then very large. Then the QRS complex widening also we will be seen, and finally the P wave may disappear. A syn wave pattern may lead to the asystole unless the emergency treatment is given. So this is the marked hyperkalemia. Here, the serum potassium is around 8.5 milliequivalents per liter. See the absence of the complete P wave we are not able to see here. Absence of the P wave, the widening of the QRS complex. This is the ECG of the marked hyperkalemia. P waves completely disappeared, widening of the QRS complex. Then the hypokalemia. Hypokalemia produces the distinct changes in the ST-T complex. The most common pattern seen in the ST is ST depression with prominent U waves and prolonged repolarization. With hypokalemia, the U waves typically become enlarged and may exceed the height of the T waves. So, what are the changes? ST segment depressions, U wave can be seen, and the U wave can be typically enlarged and may exceed the height of the T waves. So this is the normal one. See here. So here slight flattening of the T waves with the appearance of the prominent U wave, and finally the T wave inversions, ST segment depressions, and the U wave become very prominent. Right? This is a U wave which is becoming prominent, and the T wave inversions also, ST segment depressions also we'll able to see same. So here also you're able to see the U wave, right? This is the U wave. Then the hypercalcemia. Ventricular repolarization is shortened by the hypercalcemia and lengthened by the hypocalcemia. In hypercalcemia, the shortening of the QT interval is due to shortening of the ST segment. With marked hypercalcemia, the T wave appears to be take off the right from the end of the QRS complex. In hypocalcemia, the lengthens or the prolongs the QT intervals, usually by stretching out the ST segment. So these are the ECGs in the hypocalcemic normal and the hypercalcemia patients. So here in the hypocalcemia, see the QT interval increased, stretching of the ST segment. Q to T interval is almost very increased. Whereas in normal, you're able to see here in hypercalcemia shortening, decreased QT interval because the reduced length of the ST segment. This ST segment is reduced here. The ST segment is very reduced, which is widening, which leads to the increase in the QT, which leads to the decrease in the QT in the hyper. So here, as we said, due to the decreased ST segment elevation, we can see the T wave take off directly from the end of the QRS complex in case of hypercalcemia. Hypermagnesemia, usually due to the renal failure or excessive intake, does not produce distinct ECG abnormalities when only mild or moderately elevated. Pronounced elevation may be seen by prolonged PR and QR intervals, whereas in hypo, usually due to the gastrointestinal or the renal losses, may also play a pathological role in causing or increasing the severity of the hypokalemia. It leads to the ventricular epigenesis with acute myocardial infarction. So here, these are the things we discussed. This is the diastasis effect, the subendocardial ischemia, in which we have seen the ST segment depression. Here, ST segment depressions. In the hyperkalemia, where we have been seeing the peaking of the T waves. In acute infarct, the ST segment elevation, the evolving infarct, where we have seen the T wave inversions, and the hypokalemia, these are the U waves. So these are the abnormalities. Then the hypothermia. Hypothermia, the J waves, Osborn waves, prolonged PR, QR, and QT interval is seen. See here, these are the Osborn waves. This is a J point. And the shivering artifacts, ventricular ectopics, cardiac arrest due to VT, ventricular fibrillation or asystole. This is the systemic hypothermia ECG, patient ECG. Here we are able to see the J point, Osborn waves, that is referred to as the Osborn waves. So, thank you.